So the problem with rejection and transplants is that the immune system attacks the cells in the kidney or the other part of the transplant. Is there anything general about our immune systems that's abnormal, or I should say, is there anything that's normal about our immune systems in modern environments? It sounds like everything else is fouled up because of our diets and our lack of exposure to pathogens and worms and that kind of thing. What do you think?
I think almost by definition, if I use my first definition, so I always like mission statements.
Okay.
So if I look at the mission statement and I were running the immune system, my mission is I'm going to deal with perceived threats in the world. I want to get rid of the perceived threats with the least damage to myself.
Mm-hmm.
So if the environment changes, the perceived threats change. If the perceived threats increase, then obviously my immune system effector arm probably has to increase as well.
Uh-huh.
And so it only makes sense if a system that's meant to surveil the world and the world changes, that the system must change.
So the world can change in two different ways, I can imagine. One is increased threats, and the other is decreased threats. And paradoxically, it seems that decreased threats, by not being exposed to so many bacteria, viruses, and worms, kind of increases the immune system response.
And it makes sense, again, if we learn about the perception of threat.
Okay, go on with
as
more
opposed to threat. So it's not the number of antigens, it's the number of perceived threats. So if we learn that this antigen is not a threat, it doesn't count as a perceived threat because it's no longer perceived as a threat. So I purposely use the word perceived threat.
Oh, got it. Right.
And so if we learn early on, we can live with this,
Mm-hmm.
then it's not a perceived threat. So
Mm-hmm.
rather than adding up antigens or bacteria, we should be thinking about perceived threats
Right.
to the system.
I was very curious from our conversation before, Bruce, about the possibility that rates of rejection of transplants might be influenced by a person's microbiome and how many doses of antibiotics they've had in their lifetime and that kind of thing. Has anybody looked at that?
There's been a lot of basic research on that. There's profound effects of even one dose of antibiotic on the immune system.
Making transplants more or less likely to be rejected?
In most cases, it looks like there's an upregulation of the
Okay.
immune system, to the point where, at a clinical level, treating patients, I've become afraid to give an antibiotic.
Is that
I mean,
right?
I will do it because that's the standard of care.
I'll bet for a lot of transplant surgery they give antibiotics routinely.
Yeah, and I worry about that. I actually am now, now with the basic information that we have out there, I think almost anyone who reads the basic literature will be a little bit worried about, well, the urine's a little bit dirty, it's a kidney transplant, or, you know, there's a heart transplant patient, he has a little bit of fever, let's give him antibiotic.
Right.
Because I personally don't know what I'm doing to the immune system. I know I'm dramatically changing it.
So one could do a study where you gave, you know, a lot of antibiotics or not so many within a safe range to see if that influenced outcomes.
Certainly immunologic outcomes. You need a high sample size to look at, you know, hard outcomes of graft survival and so forth. But
And you could even do things like, you know, saving people's microbiome and reinserting it later to see if that influenced outcomes.
Yeah, or at least immunologic outcomes.
Right.
You know, because there's
But
so
what
many.
you really care about is whether it's rejection or not.
And that gets, well, maybe gets to the point of what is rejection.
So what is rejection, Dr. Kaplan?
So classically, we thought of rejection as acute T-cell rejection. Because that's
T cells are white cells that attack those
white
antigens
cells
in the
that
cells.
T cells that attack antigens. Because we used animal models, and in animal models we saw the first stereotypical reaction to a foreign MHC antigen, a foreign antigen of a non-self.
Mm-hmm.
And the first thing we see is a T cell activation, which forms a compartment of killer T cells.
Mm-hmm.
And that became the sine qua non of rejection.
So what you see under the microscope.
What you see under the microscope. But that specific rejection of T-cell mediated, what we call T-cell mediated rejection, which is a very specific form of a compartment forming of killer T cells within the tubular epithelium, because it was kidneys that were first studied.
Mm-hmm.
But I'll take a more broad view that rejection is the immune system attacking the organ. And we now know that it's not just killer T cells, it's macrophages, natural killer cells, plasma cells, antibody, innumerable molecules can attack. And we know that
So
what
it's
we
not
used
so
to think of
simple
as
as a-
rejection.
Antigen T cells kill. There's much more to it.
And we also know that we can see nothing under the microscope. But if we've upregulated certain molecules, even if we don't see anything there, that transplant is not going to do well in the long run.
So let's go on in a minute and talk about biomarkers that might predict transplant rejection.